first condition I'm going to talk about is acromegaly, which is the pituitary gland disorder. And it results from the pituitary gland, usually due to a tumor, secreting too much growth hormone. So in children, this will cause giantism because their long bones can still grow, so they'll have an increase in height. But with adults, unfortunately, their long bones don't grow, so they have widespread overgrowth of their skin, bones of their forehead, jaw, feet, and hands. And then their organs have enlargement, including the liver and the heart. So you can also remember that this is going to put them at risk for hypertension, diabetes, and heart disease. Now, when you look at somebody with acromegaly, they're going to have increased frontal bossing, which means their forehead is going to be larger, almost like a caveman um, um, forehead, okay? They're going to have something called prognathism, and that means like the lower jaw grows out, okay? And the lower teeth are going to be out. And they'll have a loss of oval features, facial features. The lips are going to thicken. The tongue is going to thicken, okay? They're going to be at risk for arthritis, blood pressure problems, the hypertension I talked about, carpal tunnel syndrome, as the tissue presses on the carpal tunnel nerve, diabetes, enlarged organs, and field deficit, which means they can't see as well. Again, with adults, they're going to have no increase in height because their long bones are sealed and can no longer grow. But that means they're going to have larger features of the face, a large tongue. They're going to have gynomastica. They'll have widened bones in hands, feet, forehead, and jaw. Okay, they may have a goiter. And then their visual fields can be like diplopia, which means double vision. And they could have field deficits, like eye field deficits or vision field deficits that cause some degree of blindness. The treatment includes radiation treatment to the pituitary gland, a hypophysectomy, which I'm going to go into more detail, and that's removal of the pituitary gland. And you have to remember, once the pituitary gland is removed, patients will need to be on hormone replacement therapy for the rest of their lives. Octreotide is also called somatostatin, which blocks growth hormone, and bromocriptine, which is a dopamine antagonist. So if your patient is put on this to counteract the effects of acromegaly, you need to notify the provider if they have chest pain, if they get dizzy, or if they have watery nasal drainage, because this drug, one of the side effects is leakage of CSF fluid. So remember, you can also do your halo or glucose, test it for glucose, to determine if it is cerebrospinal fluid. Another pituitary disorder is called SIADH, or Syndrome of Inappropriate ADH Secretion. And this occurs due to a lot of things. It could occur because you gave your patient morphine, so drugs can cause this. It could occur due to brain conditions such as a brain tumor, meningitis, subarachnoid hemorrhage. It could also occur with lung conditions such as pneumonia, or some lung cancer secrete ADH. Hypothyroidism can also result in it. And there's two types. There's neurogenic and there's also nephrogenic. We're going to talk mainly about neurogenic because we're doing a neuroendocrine type lecture. So some of the signs you'll see is related to the fact that since this is antidiuretic hormone circling the body, water is reabsorbed in the kidney tubules, and it's going to result in them being soaked inside. Okay, so too much water weight on. They're going to have a high specific gravity, and they will have a low sodium, which is why most of the signs and symptoms of this condition occur. They are going to be at risk for pulmonary edema. So you're going to look for those signs, right? Crackle, shortness of breath, dyspnea on exertion, pink frothy sputum. JVD, S3 heart sound. Look for all those signs of pulmonary edema. And I forgot to mention, so the low sodium occurs due to hemodilution because there's so much water in the vascular system because they're soaked inside. Again, recognizing cues of SIADH. The cues are mostly going to be due to fluid overload and having a low sodium level. So you can use the mnemonic SIADH. So S stands for sodium is going to be low. Serum osmolarity is going to be low. And they are going to be at risk for seizures due to low sodium levels. So revisit your seizure precautions. I stands for irritability, and that is a sign of low sodium. They're going to have increased weight because of the water weight. They'll have anorexia, which is a sign of low sodium. They're going to have a decreased LOC, decreased urine output, and decreased strength, all signs of low sodium. And they'll be drowsy. Okay, so you'll see a change in LOC. They're going to have a high specific gravity and a headache. Okay, low sodium causes a headache. And you start to worry when the sodium goes below 120. Okay, some of the interventions you would do for somebody with SIADH. First thing, stop free water, which means they're going to be put on a fluid restriction of 800 to 1,000 to maybe 1,200 milliliters per day. You want to also make sure you increase salt in the diet. So in other words, if they're taking PO, like they're eating, you're going to liberalize salt in the diet. Usually patients love this. I know I would. So they can drink soda, soup, sports drinks. And then if they have an NG tube or a gastro tube, you want to use normal saline to flush enteral feedings, okay? You're going to put them on I&O because you want to keep track of that. You want to make sure they haven't gained weight. You want to assess the neurological system, especially as the sodium drops. You want to definitely assess that. The drugs they can take include the Vaptin, so tolvaptan. They need daily weights, and they could possibly get hypertonic saline, which is 3%. Now, with that, you need to watch for fluid overload because that's hypertonic, right? It's going to bring more fluid into the vascular system. But the reason they give it is because if the sodium is below 118, that could be dangerous and the patient could start seizing. With the Vaptin medication, it allows for diuresis without electrical imbalances. So that's why they would order that. There's also a tetracycline. It is called demeclocycline, and that causes a nephrotoxic diabetes insipidus, which you haven't learned about just yet, but that means it causes the kidneys to diurese. So that's why that might be given. A hypophospectomy is a surgical procedure where the physician either goes through the nose or the top of the mouth palate up through there to reach the brain to remove the pituitary gland. Post-op care, you want to prevent increase intracranial pressure, so you're going to keep the head of the bed dirty and all those other things you learn, interventions for preventing increased intracranial pressure like no flexing, etc. No blowing the nose or coughing because you don't want to increase intracranial pressure. You'll have to explain to the patient they're going to have to mouth breathe after surgery. Usually the nose is packed. It has a mustache dressing if they went through the nose. So explain to mouth breathe. You're going to test any drainage for halo and glucose to make sure it's not cerebral spinal fluid. No bending at the waist because that's going to increase intracranial pressure. No brushing their teeth. They can floss and use those swabs and monitor for meningitis because they may get an infection. And then nasal pad is removed by the surgeon in 2 to 3 days. So those are the nursing implications of a hypovasectomy. Anybody that has this surgery is going to be on hormone replacement for the rest of their lives. Diabetes insipidus is a condition of the pituitary gland. Frequently can happen like after surgery, like the hypovasectomy. It could also happen because of a traumatic brain injury. So something in the brain has triggered the pituitary gland or damaged the pituitary gland, and it can no longer secrete ADH. So the patient becomes very dry inside. Now, diabetes insipidus has nothing to do with glucose metabolism. This is strictly about ADH being turned off and the patient putting out copious amounts of urine. The first patient I ever took care of as a nursing student in my ICU rotation had a TBI. And by midday, it was a good experience for me. By midday, he started putting out copious amounts of urine. And the characteristics of the urine, it was like almost like water. And at that time, this is like back in the 1980s, we used to do bedsides for specific gravities. And so every hour I was checking the specific gravity, and it was like water. It got so low. But that was a good experience for me to see. But what I'm trying to point out is you can't even keep up with emptying that Foley. It's like you empty it and then you turn around and you need to empty it again. So they're putting out so much water, they're going to get dehydrated. Risk factors, I think I talked about this a little bit, could be craniotomy, TBI, patients that have radiation to their brain due to other cancers, people that take lithium or demeclocycline are going to be at risk for GI. So the signs and symptoms, remember the 7Ds of DI. They're going to have diuresis, putting out copious amounts of urine. They're going to have diluted urine. It looks very much like water. They're going to be dry inside. In other words, they're going to have signs and symptoms of dehydration. So tachycardia, hypotension, weakened pulse, or thready pulse. They're going to be drinking a lot because they're dehydrated. Decreased BP and desmopressin. It's treated with desmopressin, which you're going to look for decreased urine output if you give that. I'm going to talk about that a little bit later. All right, recognizing cues of DI. The patient is going to have polyuria, copious amounts of urine. They're going to have polydipsia, which means excessive thirst. Tachycardia, because when our bodies are under stress, the first sign is always going to be tachycardia. We're trying to get more oxygen to the tissues. Hypotension, because they're dehydrated, they're losing all that fluid. Loss of skin turgor, dry mucous membranes, which means you have to provide mouth care. Constipation, when you get dehydrated, you can have constipation, and weight loss. Now, also remember that they're going to have a high sodium level due to hemo concentration and potassium. So look out for those signs and symptoms of high sodium and potassium, such as muscle weakness. Again, with the lab findings in DI, you're going to have a decreased specific gravity, meaning it's more like water. Okay, so remember the normal is 1010 to 1030. So that means 1.010 to 1.030. So it's going to be lower than that. So you're always looking for a specific gravity lower than that. And then when you treat it, you want to see a normal specific gravity. They're going to have increased blood osmolarity. So remember, the higher the drier, and they're dry inside, so their blood osmolarity will be high. They're going to have high sodium and potassium levels. All right, generating solutions. What can I do for my patient? You're going to monitor the I&O, and that needs to be strict. You're going to measure specific gravity. You're going to get daily weights. That's the best indicator of fluid volume. Monitor labs like sodium, potassium, BUN, and creatinine, because you don't want the patient to go into renal failure because of losing all that fluid. You want to avoid caffeine, or tell the patient to avoid caffeine, and alcohol. Don't restrict fluids. They need lots of fluids, and also put them on fall precautions. All right, desmopressin for DI. Desmopressin is ADH. Okay, so you're going to give it for DI because they don't have ADH. Okay, now remember, this has got pressin in it. So it presses on the arteries. Um, and the smallest arteries are the coronary arteries. So you're always going to want to monitor your patient for EKG changes, headache, chest pain, hypertension, dysrhythmias. Okay. It can be given intranasally or via injection. You adjust the dose to the urinary output. And then what you're going to have to do in case there's overcorrection is teach the patient signs and symptoms of water intoxication, like those, like for example, the early signs of pulmonary edema, like a new cough at night. You want to make sure they can recognize that before it gets to pulmonary edema. So like they need to take their daily weights.